Testosterone is a female hormone, and women produce at least as much testosterone as they do estrogen. Its role primarily is in the formulation of the reproductive health system, and it's particularly important in modulating sexual health. It is produced by the ovaries and the adrenal glands, and the levels of testosterone tend to decline with time over the years, although towards the latter years, 70 to 80 years, there does appear to be an increase in testosterone levels, which we're still trying to explain. Testosterone appears to be very helpful in terms of improving sexual desire, arousal, and orgasm. There are some women who do seem to benefit in other ways in terms of their mood, energy, and musculoskeletal symptoms. But the randomized prospective studies thus far have not proven that these are symptoms within the studies that do benefit. But I think what we need is more studies to prove that these are symptoms that testosterone can be beneficial for, but the symptoms have to be looked at as primary outcome measures rather than secondary measures where distressing libido is looked at as a primary measure. Now, the distressing libido is referred to as hypoactive sexual desire disorder. It is an American Psychiatric Association definition, but essentially it is low libido, which is distressing to the individual or the couple. Testosterone replacement appears to be safe as long as we maintain female physiological levels. Side effects can occur, such as excess hair growth, spots, acne, and some women, not regularly, but some can have some increase in weight. There can be rare side effects like voice deepening, clitoromegaly, and scalp hair loss. But I do want to emphasize that these are rare and tend not to happen as long as female physiological levels of testosterone are maintained. Testosterone treatment can be used for as long as hormone therapy is used, so we don't put arbitrary limits on duration of usage. We like to reevaluate the pros and cons, the benefits and risks, at least on an annual basis. It's important that when women are treated with testosterone, that they have 3 to 6 months at least of testosterone to see whether it's going to help or not. And then there should be a reevaluation every 6 to 12 months as to whether they should continue with it. We monitor testosterone levels at baseline to make sure that testosterone levels are not high to begin with, because if levels are high to begin with, then there is the potential for side effects to occur more frequently. And then it is important, and according to the consensus statements, that we monitor testosterone levels at least once a year, ideally twice a year, to maintain female physiological levels. The studies show that it's important that testosterone is delivered through the skin rather than taken orally. Adverse effects are more common if testosterone is taken orally in terms of liver function and the effect on lipids. So we would typically recommend that testosterone is delivered through the skin with a gel or cream. Now, the problem that we have is that the majority of testosterone preparations around the world are not actually indicated for female use. But as long as we titrate down the dosage to 1/10 of the male dose, and that seems to be an appropriate dosage for women to use, approximately 5 milligrams per day. There is one preparation, a testosterone cream, which is licensed in Australia and can be imported to the UK for female use. But unfortunately, this is only available privately at the moment.